This is video history from the J. Jacobs Library for the History of Obstetrics and Gynecology in America. And we're certainly pleased to have with us this day, a nice sunny November afternoon in 1985, Dr. J. Jacobs himself. Bay, thank you for coming over to visit us today, because after all, the library bears your name, and certainly we want to know something about you as part of our video history. Let me begin by asking you to tell us something about where you grew up and went to medical school and got started in practice, all those sorts of things that help shape each of us.
Well, I grew up in New York City and was never too impressed with New York City, because I always felt that I wanted to be where I could breathe easily and so on. And but at any rate, I was educated to a large extent in New York City, and then felt like I wanted to go some other place. And when I saw Washington in those days, I fell in love with the city. It was I had never done much traveling, but I was impressed with the cleanliness of the place, with the monuments and the whole arrangement. And I decided that when I graduate, I will proceed in this city, because I like everything about the city.
So you chose Georgetown for a medical school?
Yeah, and I knew what I wanted to do because I had worked with some good men in New York City. For instance, my friend Robert Emery Brennan, who was probably one of the best surgeons in New York, and he had asked me to stay with him for 5 years and he'd make a surgeon out of me. Very high-class guy, very fine-looking, never forgot a name or a face, remarkable fellow. And he operated on Rudolph Valentino and Jack Dempsey, and he was very well known. And I wasn't interested in doing general surgery. But I had worked with other men. Dr. Alfred C. Beck, I knew him before long before he published his textbook. I knew him when he was working on his textbook. I can tell you some interesting things in that regard. And there were some other prominent men who were very nice to me. And I also worked with Potters, Irving Potter and his son Milton, and we got to be very close friends.
What was it that made you choose obstetrics instead of general surgery?
I thought that I could, I don't know, I tell you the truth. I had an idea that maybe I could accomplish more. There were so many general surgeons, and I also thought that perhaps I could become proficient in less time. Most men, especially at that time, wanted to be surgeons and so on, and I would think that it would be difficult to, although to succeed, you know, as a surgeon, although with the help of Dr. Brennan, I don't think it would be too difficult, because he was a man that was admired by everybody, and I thought the world of him.
What years then, once you decided on obstetrics, were you at Georgetown?
Well, when I was at Georgetown, I had a general internship, and I had a very good impression of Sloan Hospital for Women, and I took the time to go there, and I met a man named Warren Hildreth, Hildreth, who was quite a gentleman, and he was very nice to me. In those days, you really had to know somebody to get a good appointment. And of course, many years afterwards, it changed to where even the best places were accepting individuals concerning whom I don't know whether they knew much about their knowledge or training and so on, because a lot of them were imported. And I've had a lot of experience with them, and I often wondered how these fellows would get along after they're trained, and how many patients would go to them and so on. But it's surprising how well some of them have done, and the fact that patients more or less prefer them, and I can't understand why, because I helped to train some of them for a period of years, and some of them I would say were fine, but I just didn't know much about many of them.
Well, let's talk some more about you.
Yeah?
There are lots of things for which you're known, and perhaps first of all we could talk about what I guess is one of your great service contributions to the Washington area. That is the home birth service, which you ran for so many years. Could you tell us some things about that?
Yeah. Well, shortly after I graduated and had training, I was interested in doing clinical work and in teaching. I think I was more interested in that aspect than I was in earning a living, because in those days I didn't care much about office hours. I was attracted to the free clinics, and I knew there were certain things that I would like to develop. I had ideas pertaining to them, and I didn't have many private patients in starting out. I was not interested in assisting somebody, because I felt that I wanted to promote myself through my own efforts, and I thought that I didn't care to be known as somebody's assistant. Maybe I was narrow-minded in that respect. And I imagine I encountered more difficulty financially than the fellow who would go out and assist somebody who was very busy and well-known and so on. I imagine a fellow of that type was a little more comfortable with the income, in which, although I did a few other things that gave me some income, and for one thing, I sort of had to find a source of income, and for a short time I worked at what we call the pension office, and beautiful building in Washington, remarkable building. And the doctors in that building were real old fellows that never practiced, but they were all nice fellows, and they were very nice to me and appreciated having a young man with training in their office. And I had the privilege of leaving when I wanted to conduct a clinic and things like that, because I was always interested in clinical work, although it didn't pay anything and took a lot of time, but I felt that I could use some of these clinic patients for research, which I did always, see. And until the Secretary of the Interior, who was in charge of this arrangement, notified me that I would have to put in the whole day like everybody else does, and I could not leave when I wanted to and so on, and so I resigned. And I went to his office and told him that I was going to resign. Of course, that was in the old days, you know, and he said, "I'm surprised because I don't know of anybody that would turn down a salary of $2,400 a year when he doesn't have anything." See, in those days, $2,400 was a fair income. The chiefs of government departments were getting about $3,000, see. And I said, well, I have my choice. And he said, that's right. And I can't understand why you want to quit. Well, I knew why I wanted to quit, because I saw all these old fellas sitting around there, been there for years. They're nice gentlemen. They're very nice to me. And one man in particular, as a matter of interest, was a black man who had been a slave when he was a young boy. And we became very good friends. This fellow had remarkable characters. And we would visit each other and so on. And he had a son that was an associate professor of surgery at Freedman's Hospital. And he had a daughter that I think was a president of some black school and that sort of thing, and so on. But gradually, by persisting in clinical work and accumulating all this clinical records and all, which I did, and then I began to devise instruments such as the...
Why don't you tell us about some of the instruments you've devised, since you brought some with you today?
Well, for one thing, when I was at Sloan Hospital, Dr. William E. Caldwell was in charge of the clinics and teaching. And I got some ideas there. And I remained somewhat in touch with Dr. Caldwell. For instance, I devised the obstetric mannequin for one thing.
And maybe I can help you hold this.
And this fastens to a tabletop. And then I devised a fetal skull which theoretically represents the skull of a newborn baby in proportion. Like, for instance, it's all built to scale by parietal diameter and by temporal and so on. And incidentally, I might say that I came to the conclusion after many years of clinical work and development of new devices and all, I decided that the biparietal diameter, and this goes back to about 1933 or so, which is over 50 years, is the most reliable index of maturity, of fetal maturity. I may be drifting from one subject to the other, but it's all advances in obstetrics, see. And recently, it amuses me, in the last several years, they've gotten around to realizing that the biparietal diameter is the most reliable index of fetal maturity, and I had published that observation over years.
Bay, why don't you let me hold that for you, and maybe you could show us about the Jacob's inclinometer that you have.
Now I have often used this pair, that is the fetal skull, and this is a pretty accurate reproduction of a normal female pelvis. In fact, I also have a pan. After this is attached to the table, I have a pan that fits onto this arrangement, which would represent the posterior surface of the uterus, and you could use a normal stillborn fetus and demonstrate the various types of mechanisms and deliveries and so on, and various types of forceps which I had devised, and especially for teaching purposes, see. Now, with the inclinometer, these were manufactured in Germany by the Max Wolker Company of Cincinnati. And I started by doing something we used to do in the clinics at Sloan Hospital. We would measure the height and the inclination of the symphysis. And this scale, of course, gives us the height, and this pendulum would give us the inclination. It's calibrated in angles of the symphysis toward...
I'll hold the box there so you can show it a little bit better.
Toward the horizon, see? And it took quite a bit of experimentation to develop this thing accurately, because in the first model that I made, as you separated these two arms to place one knob on the top of the symphysis and one on the lower border of the symphysis, if the one arm was attached to this disc, and then the other one would move. Well, it is necessary for both of them to move simultaneously in order to get an accurate reading of distance. Mm-hmm. In other words, this had to be remodeled, see, and it works on gears inside of this device, and that way you can measure the height of the symphysis, and this part would give you the inclination of the symphysis. So with that in mind, I wondered if we couldn't measure some more distances in the pelvis, and perhaps the angulation of certain planes of the pelvis. And it seems like everything just came along in order. In other words, I was able to measure the height and the inclination of the symphysis. Then I proceeded to want to measure the diagonal conjugate and its inclination. I finally got to where I was able to construct what I called the Obstetric Triangle. That is something had never been given it consideration before, but I thought it was very important. And I could then find out exactly, knowing the height and the inclination or angulation of the symphysis and the length and the inclination of the diagonal conjugate and the angle in between the two, which I call the obstetric angle, I could then calculate the length of the true conjugate diameter. Now, that had not been done before, and I was able to work on through with this thing to where I could determine the length of the true conjugate. Now, for instance, we were always told that Smelly's rule applied if you wanted to determine the length of the true conjugate. In other words, Smelly stated that if you measure the diagonal conjugate, then you subtract 1.5 centimeters, and it gives you the length of the true conjugate. Now, after many, many observations of this type and carefully constructed tables for the patient to rest their thighs on, and I would operate in between these two tables because I didn't want the patient to tilt her pelvis in any way, I found that Smelly's rule of determining the length of the true conjugate diameter from the diagonal was accurate in about 8% of cases. See? And actually, the true conjugate depended upon that obstetric angle and the side. So you see, the true conjugate in a woman's pelvis could vary a lot depending upon that obstetric angle, see? And then, of course, we measured the conjugate of the outlet and things like that. And I found also that these observations were reliable. I could measure a pelvis with the inclinometer. Incidentally, if you're going to measure we'll say the diagonal conjugate, then we take this device and this rod here, measuring rod, and we assemble this thing, and in order to measure the diagonal conjugate, or the conjugate of the outlet. And inasmuch as I was never too good in mathematics, I devised this calculator so that I wouldn't have to use a mathematical equation. Now, for instance, we fasten these parts together, and we put this portion in place, and this is calibrated for the diagonal conjugate, and of course the finger is inserted here, and this knob is placed on the sacral promontory, and we gradually lift this measuring rod upward to touch the lower border of the symphysis, and we also read the angulation of that plane. And so that helps us to determine the obstetric angle, see? In other words, we've already taken the inclination of the symphysis, now we get the inclination of the diagonal conjugate, and then we have the angle in between the two. So we have the length of the diagonal conjugate and its inclination, and we have the height of the symphysis and its inclination, and then, and of course this gives us the angulation, this swinging pendulum does, see, of those planes. Then we can disassemble this and we just take it apart, and then we have a calculator here, and we add the inclination of the symphysis to the inclination of the diagonal conjugate to give us the obstetric angle. And if the obstetric angle, we'll say, was 45 degrees, I'm taking that, I'm presuming that's what it might be, then we raise this scale, which represents the symphysis, and this calibration here represents the length of the diagonal conjugate. Now, so we bring this scale up, see, and that's the diagonal conjugate. Now, we can slip this thing, this is calibrated, and we can slide it along to the length of the diagonal conjugate, and we just fasten it in place, and of course where these scales cross, that would give us the length of the true conjugate. Because we got the height of the symphysis, we place this on that point, we got the length of the diagonal conjugate, and we set this marker right here at that length, and then if we just place this at the height of the symphysis, this particular scale gives us the length of the true conjugate. And we find that the true conjugate has no relationship at all to the diagonal conjugate. And it all depends upon the angle in between, which is I refer to as the obstetric angle. And of course we can go on with this in a very interesting way. We can just take a sheet of paper and a protractor, which is this part's a protractor. See, we get either a cardboard protractor or a brass protractor. They're very inexpensive. They used to cost about a dime for a brass one, see? And you can draw the, you can reproduce the whole interior of the pelvis on a sheet of paper, and you can include that in the patient's chart.
Bay, you've done enough innovating that we're never going to get it all on one tape.
Yeah, well,
what will
so we just mentioned things briefly then.
Yeah, well, I think what we probably need to do, in deference to talking about the reverse forceps and some of your other innovations for which you've been responsible, is to make a second tape and get all this information down in some more detail, because we really can't do justice to it today.
That's all right.
So let me
yeah, sure.
Bay, thank you for being with us today, and for having explained the inclinometer, which I think will be something entirely new to most of the people who've looked at this.
This thing, is that off now? Well, no, what I was going to say is, unfortunately...
We're just going to have to do another tape to get everything
yeah,
on.
Well, that'll
never
be
get
all
everything
right.
on
I had 50 of these, which I had planned to turn over to medical schools that might use them for teaching, but then they developed a playground next to my property, and the kids broke into the building where I stored these things and stole the whole box of 50 and probably sold them to a junk dealer for a few dollars.
Is this the only one you have left?
Yeah, this and one other. The other has been built to accommodate a set. It's a leather container, you know.